Welcome, everyone. My name is SWETA TEWARY, and I'm an assistant professor with the Department of Geriatrics, Nova Southeastern University. I'm also the administrative director for the Geriatric Workforce Enhancement Program, a federally funded project through HRSA. So in my next two videos, I'm going to present information about sleep and how sleep affects older adults, especially persons with dementia. Part one of the Sleep and Dementia series, I'm talking about how sleep works. And in part two, Sleep and Dementia, I'm discussing some of the strategies which can help older adults, especially persons with dementia, sleep better. I'm also including a summary result of our caregiver sleep study, which we actually completed a few years back. But the summary results will help us understand what really worked for the caregivers and their loved ones to sleep better. So if you have any feedback or any questions regarding the presentation, feel free to put it in the evaluation form and we'll be happy to look at it and improve our work. Thank you. Welcome everyone to the Sleep and Dementia series part one. My name is SWETA TEWARY. I'm an assistant professor, Department of Geriatrics. I'm also the administrative director for the Geriatric Workforce Enhancement Program, Nova Southeastern University. This presentation is supported by grant funding from HRSA. The principal investigator is Dr. Nashira Pandya. Affiliations and disclosures, I have no conflicts. The two learning objectives which we'll cover during the presentation are: describe the importance of sleep in older adults among persons with dementia, and we'll learn how sleep works as we age. So let's review some important facts about sleep and dementia. Sleep is a common complaint presented by patients with dementia. We are going to call them PWD in this entire presentation. Lack of sleep is also associated with physical and cognitive decline. Approximately 2/3 of the caregivers of PWD also have sleep issues. In fact, caregiver sleep is one of the most cited reasons for institutionalizing their loved ones. Sleep pattern among persons with dementia. Sleep is qualitatively different in PWDs. It becomes somewhat more shallow and broken as we age. As we grow older, we may also notice a decrease in the quality of sleep we obtain. Illnesses that cause dementia, such as Alzheimer's disease, further disrupt the sleep. Alzheimer's disease and other forms of dementia also affect the PWD's ability to think clearly and remember things. If they become confused, they may wake up at night, they may wander, they may get upset, further disrupting the sleep of caregivers. An important concept known as sundowning is where persons with dementia are actually napping during the daytime and they may get agitated in the late afternoon. One question which I want everyone to think about: how many times do you think our body is programmed to feel sleepy? Once, twice, or multiple times? Well, the experts inform that there are two distinct periods when our body feels sleepy. The primary period is between midnight and 7 p.m. and the secondary period is between 1 to 4 p.m. in the afternoon. Coming to the stages of sleep cycle. Now, in past, experts have believed that there were 5 distinct stages of a sleep cycle. However, over a period of time, these have been consolidated into 4 distinct stages, which we are going to discuss in this slide. Now, there are 2 basic types of sleep: rapid eye movement sleep, the REM sleep, and the non-REM sleep, which is 3 different stages like the N1, N2, N3. Each is linked to specific brain waves and neuronal activity. Now, we cycle through all these stages of non-REM and REM sleep several times during a typical night, with increasingly longer, deeper REM periods occurring towards morning. Now, stage 1, which is the N1, as you see in the chart, is a non-REM sleep, the changeover from wakefulness to sleep. Now, during the short period, which actually lasts several minutes, of relatively light sleep, our heartbeat, our breathing, and our eye movements, they slow down. Also, our muscles will relax with occasional twitches. Our brain waves may begin to slow down from their daytime wakefulness patterns. Stage 2, or the N2 non-REM sleep, is a period of light sleep before we enter into deeper sleep. our heartbeat and breathing is slow, our muscles are relaxing even further. Our body temperature drops down and our eye movements stop. Now, brainwave activity also slows down, but is marked by brief bursts of electrical activity. We actually spend more of our repeated sleep cycles in stage 2 than in any other sleep stages. So basically the maximum time is in the N2 or the stage 2 of the non-REM sleep. Stage 3 of the non-REM sleep is the period of deep sleep that we need to feel refreshed in the morning. It occurs in longer periods during the first half of the night. Our heartbeat and breathing slows down to the lowest levels during the sleep. Our muscles are relaxed and it may be difficult to awaken us. Brain waves become even slower. Now REM sleep, which is the fourth column in the chart, it first occurs about 90 minutes after falling asleep. Now our eyes may move rapidly from side to side behind closed eyelids. Mixed frequency brain activity becomes closer to that seen in wakefulness. Our breathing may become faster and irregular, and our heart rate and blood pressure increases to near waking levels. And most of the dreaming occurs during the REM sleep, although some can also occur in the non-REM sleep. Interesting piece here is that our arm and leg muscles, they become temporarily paralyzed, which prevents us from acting out in our dreams. I wish we could, but no, we cannot. As we age, we sleep less of our time in the REM sleep. Now, memory consolidation, and this is important to know, memory consolidation actually requires both REM and non-REM sleep. And we'll see how this actually is associated when we age or if we have dementia as we grow older. We discussed sleep stages in the previous slide. Now let's look at how these sleep stages are influenced with age. Now, as we age, our brain waves change and we tend to experience less deep sleep. So if you look at the chart, the first pie chart where we have the REM sleep is during infancy is actually the largest. But now if we look at the old age, our REM sleep is actually reduced. So most studies also demonstrate an overall decline in REM sleep. The change in sleep architecture that occurs is associated with the aging process, but the disruptions in sleep are likely due to the impact of medical or psychiatric conditions. Let's try to understand how sleep works. Circadian rhythms. What is circadian rhythms? Circadian refers to our internal body clock, which affects many functions such as metabolism, body temperature, and sleep or wake behavior. Now, from years of research, sleep experts now know that our circadian clocks seem to work in roughly 24-hour cycles. Now, for example, if we monitor an individual's body temperature for several consecutive days, we'll see a consistent up and down variation or rhythm in temperature across each 24-hour day. The temperature will tend to be at its lowest point around 3 or 4 a.m. It will rise through the morning and early afternoon, and it will hit its peak around 3 or 4 p.m. in the afternoon. Now, subsequently, the temperature will begin to fall until it hits its lowest point, approximately 24 hours after its last low point. Now, different physiological functions have their own circadian clock, and these clocks actually have an influence on each other. For example, let's say body temperature rises, we tend to be more awake. But when the body temperature drops, we tend to become sleepier. Light is another factor that synchronizes our circadian sleep clock, which explains why we are typically awake when it is daytime or why we are asleep when it is dark or night. So it is really important to have a consistent bed and rising time and reducing daytime sleep periods so that it helps in making our circadian rhythms stronger. Homeostatic process. Homeostatic refers to the sleep drive. That is the fact that the longer we are awake, the sleepier we become. Now, for example, practices such as daytime napping, going to bed early, or sleeping and following a poor night's sleep, or even when we are watching our tablets or we are on our digital devices, our cell phone, all that reduces the body's need to sleep at night. Therefore, it is important, especially with PWDs, that we have a consistent bed or rising time and reduce daytime sleep. One thing which I want everyone to understand when they're working with their loved ones who has dementia is have a set goal and a realistic expectation in how much sleep he or she requires. Now, we must have enjoyed like maybe 10 hours of sleep during our adolescent years. That doesn't mean that we'll get the same amount of sleep as we age. It is going to reduce. Also, individually, each one has a different sleep drive. Some may be okay and functional with 4 or 5 hours of sleep during the night, and some may need longer hours of sleep to be able to function the next day. So when we are setting goals and requirements while working with our loved ones with dementia, have a realistic expectation about sleep patterns. Now I'm going to end the part 1 series of sleep and dementia. Please enter your feedback through the link or scanning the QR code. Thank you.